Seeds, Other Sides of. Oh, hello, guys. Welcome to Sowing Seeds, Other Sides of Medicine, Not Practicing. I'm so glad that you guys can join us on Facebook and YouTube Live. My name is Takara Newsom QB. I'm a third-year medical student at Kansas City University. And tonight we have two lovely guests. We have Dr. Gray and Dr. Matthews. We have one potential guest, Dr. Green. She may be joining us later on, but for now, we're just going to proceed with our two guests here. So first, I'll introduce Dr. Gray. He's gonna talk briefly about where he is, what his position is, and a little experience, and then we'll go on with Dr. Matthews. So thank you so much, Dr. Gray, for being here. If you would like to introduce yourself.
Thank you for having me, first of all. Really excited to be sitting alongside Dr. Matthews here. And thanks for Dr. Green, Lisa, for inviting me to participate as well. It's truly a pleasure. I'll tell you, for those who are participating, it wasn't too long ago that I was in your shoes or seats. I am an alumni of Howard University College of Medicine and graduated from Howard in 2007. I got to think back a little bit far. I now get to serve as president and CEO of WellPoint Maryland. WellPoint Maryland is a Medicaid managed care organization in Maryland. We are the second largest. I get to serve over 300,000 people across Maryland, every single county. And I manage a large staff of people to help me to do that. This was a somewhat non-linear path to getting here, and not something that when I was in medical school, I even envisioned or even thought possible for my career. Very briefly, after leaving Howard University College of Medicine, I went to internal medicine residency at Duke. Then I did a gastroenterology fellowship at Washington University in St. Louis. After that, understanding that I wanted to go into public health as well as applying health policy to my career, I pursued the Commonwealth Fund Fellowship in Minority Health Policy at Harvard, T.H. Chan School of Public Health. And then subsequently spent most of my career, my academic medicine career, as an academic gastroenterologist in Ohio. So I practiced at the Ohio State University Wexner Medical Center. I served as also the deputy director of their Center for Cancer Health Equity there, where I did research, a lot of community engagement, and practiced clinically as a gastroenterologist. And it wasn't until August of 2021 when I made a pivot to join Elevance Health, which is the parent company of the company I now serve as CEO for. So I've been in the insurance side of healthcare for a few years now, and really loving it. So I'm excited to share more and excited for your questions. Back to you, Takara.
Wow, what a rap sheet. I am so impressed. You've been everywhere. It sounds like you've done a little bit of everything. Howard, Duke, Ohio. So you have a quite a journey. So we'll love to get more into that, to see how it went from internal medicine to GI to insurance, because I'm sure you did not see that, when you were in residency as an internal medicine resident, that you're going to end up as CEO of a well-known insurance company. So that's very, very impressive. Thank you so much for sharing. Dr. Matthews, would you like to introduce yourself as well?
Sure, great. Very honored to be
A
here.
hard act to follow.
Very happy to be here, and actually really excited that you're having this conversation. I think your final point there, Takara, that students need to kind of recognize that there's a much larger scope that physicians should take. It's not even that you can, but that we need more clinicians in these leadership roles. So I'm really glad we're having this conversation. Let's see. I am originally from Philly, and of course feeling the pain of the playoffs, but that's okay. Went to undergrad at Duke, so we crossed over not in the same years, probably. I think it was a little earlier in my career. Then Johns Hopkins for medical school, so Region 6 of SNMA. Very proud of that. Where I decided somewhat early on that I wanted to get involved in a little bit more than clinical medicine. So I actually took a leave of absence after my third year and stepped away to Chicago, where I got my law degree at the University of Chicago. It was very much more so because I was interested in solving the problems that our government often has a hand in, that is actually causing our patients to come in to see us. That I think early on, now I have the language behind it. We are a very reactive healthcare system, and I wanted to come up and be a part of the solution on how we should instead be preventing that disease and keeping patients away from the hospital. My residency was at University of Illinois at Chicago in family medicine. I'm a proud second generation family doc, really focused on preventive medicine, obviously, and continuity of care. Thought I was going to go back into law. My faculty in residency, if you talk to them now, they were like, yeah, she never wanted to focus on medicine. But I realized towards the end, it wasn't that I disliked medicine, it was that I disliked residency. Like, I was so miserable that I thought I was planning on going back to law. I can't take this. Because I had already sat for the bar. I was like, I can go to a law firm, I could do this. But really, it was my elective, my second year of residency, when I realized no, you actually do love this, you just need to get out of this academic environment. And that was when I did an elective at Cook County Jail on the west side of Chicago, really getting a handle on, to me, the most discriminated patient population that you'll ever be able to have the honor of serving. We can discriminate against them for our employment, licensing, education, housing. If you ask about anything on an application nowadays, it includes criminal background. But yet these are people serving their time. So I felt very honored to be a part of their healthcare. Took my first leadership role there, created a committee where I was working with the correctional officers as the clinical side. Along with the correctional officers, I got to make some security decisions that were related to healthcare. Stepped away after a couple of years, wanting more leadership potential than the jail was offering. Went to my first federally qualified health center on the west side of Chicago, where I ran one site. Then I went to my second FQHC, that was west and south sides, where I became chief medical officer of the whole FQHC. So managing 13 clinics, including the 3 of the School of Nursing we were affiliated with, and actually a part of the University of Illinois where I did my residency. So now I'm back as faculty for the medical students, for the residents, and running our FQHC. I needed to come back to Philly. My mother was starting to show some signs of her illness. And I ended up joining the VA. I had done, like most of us, about 2/3 of physicians in this country end up doing some sort of training in Veterans Health Administration. And I ended up joining basically what's the equivalent of their managed care office. I had taken on a managed care medical director role at UIC, and so got familiar with utilization management and the like, and kind of the impact of the payer world on quality. But getting into the VA, learning a totally different payer system. VA has a payment system called Community Care that's parallel to TRICARE. I'm not sure if we have any veterans or active service members here, but I eventually rose up. It was the Trump administration, and there was a lot of turmoil. I actually rose up and became the assistant undersecretary over the entire managed care program in the VA. So I ran a $16 billion budget. I had 7,000 staff. And we had 2 million veterans accessing our services every year. I got to implement some legislation. So my law degree got kicked in. I was testifying on the Hill multiple times a month. I was pushing out real performance. And thankfully, it was a very smooth launch of the program that we implemented. My boss at the time then wanted me to come more in-house as opposed to this outward-facing managed care office where we were paying for care outside of the VA. He then asked me, and I stepped into the assistant undersecretary for clinical affairs role, which is chief medical officer of the entire VA health system. So I did that during COVID. I helped partially move forward with our EHR modernization program, which in and of itself is a beast. It's still a beast for them. But in the end of 21 and starting in January of 22, I turned towards a friend of mine, Toyin Ajayi, who had founded this pretty amazing company called City Block Health. And I decided to step away from the federal government after about 5 years and join City Block as the chief health officer, where I have been now for 2 years. So we are a value-based care, primary care practice that integrates behavioral health as well as social services for Medicaid populations and dual eligible programs. We're across 7 states currently. We have about 100,000 members within our practice. And it's pretty amazing. I'm designing a model that is fit for form for Medicaid populations. Most health equity work, if you really dig into it, is designed for other commercial products and Medicare, where instead we're really focused on making sure we're meeting our members where they are, understanding their needs, especially in the behavioral health space. We take care of a great deal of serious mental illness and addiction across all of our primary care teams. And we have a community health worker model where they are really at the lead. The physicians, were just at the back writing the prescriptions. It's really about the community health partners, as we call them, who are by our patient side. I love this transformative model. It's not the typical primary care practice. And so I love being a part of this innovation and basically using all my experiences across my other clinical settings to get to this point of designing and running a multi-state practice that's really looking to be different and provide different outcomes for our patients. So yeah, I tweaked my clinical time over the years. I mean, talking about getting out of practice, let's see, at the jail, my first role, I think I was like 95% clinical. Then I moved to 75% clinical. Then I moved to 40% clinical.
Oh, wow.
Now, and at the VA, I only volunteered telemedicine, and now I'm only taking overnight call and supervising our NPs.
Okay, so you still have some clinical capabilities. Okay.
With every successive position, I've taken less time because these roles, they take a lot out of you. And sometimes you need to step back and prioritize your own self-care and not use your volunteer time on the weekends to see patients. I'm given enough of my time to take care of a much broader set of patients than I ever could in clinical care alone. So it's been a progression away from clinical care over the years.
Absolutely. Wow. I am amazed with both of our amazing speakers tonight. You guys have some amazing stories and journeys through medicine. Dr. Matthews, sounds like you have a strong passion for the underserved communities, starting with the incarcerated, the veterans, our patients that are on Medicaid. You are serving them. And so thank you. We need more of you out there. And so I'm sure we do not.
We need more students like you to know that these opportunities exist.
Yes,
this is often not what you're exposed to in medical school. I didn't see any of this.
Both of your experiences, that's not what we're taught when we're in medical school, not as a first year, second year, third year. You think of practicing as a clinician and staying in that specialty that you go to residency for the remaining of your life until you, possibly retire. So it's very good to hear these other sides of medicine, because it sounds like they kind of show up as an opportunity. They present themselves. You don't go to school thinking that you're going to end up being the CEO of Wellland or having your position. It's like you go through medical school, you go through your training, work as a physician, and then these opportunities arise where you take them. Is that how you see it, or do you think?
Takara, I'll say yes, or I'll add a different spin to it.
Okay.
I think it really aligns with first understanding your purpose. Okay. What do you feel that you as an individual are called to do? And then taking the steps, building the building blocks to get you to that place. I recognized a while ago that my purpose is to architect systems that allow all people to lead healthier lives. And so in order to do that, and I followed a passion and an interest in internal medicine, kind of taking a very holistic view of medicine, to then following a subspecialty, which was a niche area for me, particularly around colon cancer, because it disproportionately impacts people of color, and particularly African Americans. And so I followed that interest. But again, trying to think, and Dr. Matthews hit on this, beyond what I can change in an office visit, in a 15-minute office visit with one patient, or beyond what I could change in a full day of doing endoscopy, where I'm doing colonoscopies and removing polyps, trying to prevent development of colon cancer. I wanted to change the conditions and the systems that fostered the poor outcomes, and create better conditions for those whom we serve beyond just a one-on-one interaction. So then that took me to opportunities, or that led me to pursue opportunities that would help to broaden my mind around how I could achieve that. And so that kind of led me down the road of public health and getting a master's of public health. And how I could influence policy, and have done some things in policy at a local level, such as in Ohio. Um, Still doing research to try to figure out, well, what are the ways in which we can engage people, communities around adapting healthier lifestyles, preventative medicine approach. And then again, continuing to think about how can I broaden my aperture to be able to impact larger populations. And I would say that, yes, part of it is how I prepare myself, or the environment and crowds and peers that I surrounded myself with, the opportunities that presented themselves. But if I'm going to be fully candid and transparent and honest with you, Takar, with you, Dr. Matthews, I also had to leave room for God to do his thing. And so I'm a person of faith, and I have kind of taken my direction from where I have felt led. So as an example, when I was in academic medicine at Ohio State, things were going extremely well. I was loving what I was doing in research and bedside, at the bedside, and inpatient and outpatient, doing procedures, doing community engagement, engaging with local policymakers. I was enjoying it, but I also was sensitive to God and really did feel a leading to, when it was time to go and to pursue something else. And I've been blessed ever since, and really have enjoyed since joining this side of healthcare in health insurance. First serving as Chief Health Equity Officer, the inaugural Chief Health Equity Officer for Elevance Health. And then this opportunity to really focus my energy back in Maryland, where I'm from. I'm from Baltimore area. So to focus my energies on a Medicaid population here in Maryland, it's a highlight of my career. But I have no doubt that I would not have been here if not for God. So.
Oh, thank you. I love that spin, that different perspective that you put on there. It sounds like you kind of didn't want to treat a symptom, but a broader issue, a preventative issue. And so that's amazing. I do want to open to the audience who's ever watching before I start with questions for the both of you. If anyone in the audience, if you have any questions or comments for our two amazing guests, please, please, please comment in the comments, and you can ask away, and we'll be able to see those comments and ask the guests those questions. So if you have any questions, please comment and let us know. Thank you again, Dr. Gray. So I do have a question for both of you, starting off just hearing both of where you both started and where you are now. I do want to know, well, Dr. Matthews, I see that you are actually still practicing as a clinician. I didn't know if you were or not, just a little bit, but you're still something there. How much do you think attaining your MD degree had on the impact of you attaining the current positions that you have now? Do you think those positions would have been available to you if you did not attain an MD? And Dr. Gray, specifically to you, are there other doctors, MDs or DOs on the insurance side of things, or are you like the lone wolf fighting for change on, the doctor side? So if you want to, either one of you want to tackle on that question.
I'll jump in first. I think, without a doubt, the roles that I've had are actually physician leadership roles. So, I haven't yet, I look up to Dr. Gray. Actually, I haven't yet jumped into that CEO space. That's a whole different space. But
you went fast. I started working and then I'm CEO a couple years later.
I know, you're managing like $16 billion budgets. Come on now, you can do it.
I had a whole bunch of people, but we were all cheering from the rafters, from the roof, when Dr. Gray got his first Chief Health Equity Officer position, and now this one. But no, the roles that I've gotten are definitely different operational focus, but hands down for a clinician. You need to understand healthcare at the individual level, at the healthcare system level, at the policy level, in order to truly be able to improve the system. And I think that's one of the faults of a great deal of the healthcare system. We have a lot of individuals in leadership positions who are not clinicians and who haven't had the experience of interacting with patients and understanding their concerns and the complexity of how our systems actually make the complexity worse, and they really unfortunately aren't thinking as person centered as possible. So I definitely have leaned into both. And this actually kind of goes to the question in the comment. I've leaned on both of my graduate degrees in my leadership roles, because one, I do speak from my knowledge and my experience as a clinician, but then also I won't call myself an attorney. I haven't practiced law. I have a law degree. That's how I describe it as compared to some of my other colleagues. But I think that has given me a foundation of really policy and governance and structure that often typically frustrates clinicians. The lawyers, we can find the loopholes, we can figure out the process. We are okay in the gray, where I think our clinical training is very kind of clean cut. There's definitions, there's expertise in areas that, yes, maybe it may not be as evidence-based, but we typically, maybe through more consensus sort of decision making, we typically have a right or wrong answer in medicine. On the policy side of the house, it's not right or wrong. It's what works now. What can you pay for? What can you defend? What can you argue? And I like that gray zone, but that's really honestly the space that we as leaders are constantly occupying. So I see the mix of my degrees, and then more importantly, my experiences since finishing my training, as being a necessary combination. So I'm glad that I got that much education, and thankfully I've been in public service long enough. I got that loan wiped out last year. So go Biden in 2024, because he wiped out my loans. But the one thing I will say though is I really think the experiences in SNMA and other student organizations that you may be involved with, in your church, in your fraternities, your sororities, these are the experiences where you're going to get that leadership training. You're not going to learn, honestly, how to manage the staff that either Dr. Gray or I have in a clinical setting. We don't learn how to manage people. We learn how to work within a clinical hierarchy, which is not the same thing. So a great deal, I think, of what we've been able to gain is on the job education. So I kind of want to push back. You said, what have we gained enough during your training? You have to get past the thought process that your training will end at some point. It should never end. You will continue to be trained on some new experience with every role that you take.
Yeah, and I'll just I'll add that we definitely need more of you in all parts of healthcare, not just clinical medicine. There are increasingly more physicians in insurance, to answer your question, Takara. As a matter of fact, the person who hired me as Chief Health Equity Officer is a physician, a colleague of both Dr. Matthews and I, Dr. Shantanu Agarwal. He's the Chief Health Officer at Elevance Health. So yes, there are more of us in these spaces. And to the point that Dr. Matthews raised, we bring a very unique perspective, a very needed perspective to healthcare delivery. Interestingly, as CEO of WellPoint Maryland, we have a network of over 30,000 providers across the state of Maryland. And it's a very different experience when I walk into their office around partnership between our company and them. As a physician. The questions are different. The kind of, matter of fact, the level of respect is different, because they know I've been in the office. I've seen patients. I understand the workflow. I understand the challenges of practice. And so with you going as a physician who's seen patients, who's practiced, who's been inpatient and outpatient, you bring a certain level of gravitas, but also just knowledge that is extremely valuable in roles like this.
Yeah, because you have firsthand experience. You you can probably account for some of the things that they don't understand. Like, why would a physician prescribe this or do this test or, have this diagnosis? And it's like, well, this is how we think. And you can give that, feedback, something that they can't. I'm just assuming.
Yeah, it's definitely a lot. I mean, as you know, there's a huge healthcare workforce challenge. And so as we think about patients lacking access to care or timely care and unable to get into the office, or having to wait months to get into the office,
Correct.
I'm able to approach that situation or that challenge that the provider's office may express to me with empathy, because I've been in there. I've been in that situation. So, yeah.
Yeah. Wow. Amazing. Thank you, Dr. Gray and Dr. Matthews, for those answers. We do have a question from the audience. And so he says, thank you, Dr. Gray and Dr. Matthews, for being here tonight. My question is for Dr. Matthews. You mentioned taking a leave of absence to pursue your law degree. I think you said you did it during your third year of medical school.
Yeah, in between third and fourth year. Yeah.
Oh, yeah. You're amazing. So the question is,
I needed a break. Law school, trust me, was a break.
you thought law school was a break? Oh, my Lord.
Comparatively. No, yeah. No, I'll jump in. I'd love to hear the same. There's dual degree programs with public health as well too. So I think it's let's make this a little bit bigger. But at least for my choice, number one, I didn't make the decision about law school until my third year. So I think in particular, I like to make sure I tell medical students, you have time to figure this out. So the dual degree program tends to lock you in a little bit earlier. I actually went to Hopkins thinking I was going to do public health. And after a phenomenal conversation with a mentor, realized that I had a different set of interests, that I was really looking more at that governance question, which law school gives you a good foundation on. So for me, I couldn't complete it. We didn't have a law school at Hopkins, and I needed to step away. The issue with the MD, JD, actual dual degree programs is it does cut out a year, yes. And it cuts out the year typically of law school. Law school is actually your stronger experience is based on your electives. So you'll be cutting a whole year of electives, of experiences of learning from your education if you do that shorter year. Some schools may actually allow you to do a good number of them over the summer, but that's actually not the full experience. In my mind, I saw the MD-JD program, 2 separate degrees, as less than the time span that many of my MD PhD colleagues were taking to get their 2 degrees, number one. And then number two, it's degrees for your full career, for your life. It is not about the immediate gratification of getting out of school. It is about the fact that I can now walk into any room, and I'm usually the youngest, the Black, the female, and the only doc that's also a lawyer in the room. Right?
Okay.
Like, okay.
We did a moment of silence for that. Okay. Here we go.
So much of this is not about the quickest, way to the end. It is about making sure that for your career, for your livelihood, for your own personal mission that Dr. Gray was talking about, that you're getting prepared as much as possible. And if that had taken an additional 3 years on top of these, I would have done it, hands down.
Yeah, Dr. Matthews, as you were speaking, I was reminded of a quote from a Morehouse brother. I did my undergrad at Morehouse, and Sean King came out a couple of years before me. And the last time I saw him was at this Black Male Conference in Akron, Ohio, several years ago. And he said something. He said, he was in his keynote address, he said, do the thing that makes you come alive to impact the issue that breaks your heart. Do the thing that makes you come alive to impact the issue that breaks your heart. So, one thing about going into a career in medicine is that things seem to be, or actually they are, very prescriptive. When you're trying to go from undergrad to med school, you have to take the MCAT. When you're going from med school, you're going to apply to residency. And if you want to do specialty, you go to fellowship. And everything is kind of very much prescribed. But there's also the opportunity, just give yourself room to pursue those things that interest you most. And what you heard from Dr. Matthews is, she had certain passions, certain interests that led her to get the JD. And then that led her ultimately to what she's now doing with City Block, right? And same thing with me, following those interests, those areas where you want to create change and have impact and pursue those things. Don't be tied to strictly kind of what's traditional or a traditional path. Don't feel like you have to be constrained by that. If you feel like your purpose is this way and traditional would take you this way.
Traditional very rarely gets you into the exceptional opportunities. I'll say it like that. It's not just about leadership roles. It's about, having, I like calling my career being based on serendipity, that opportunities have, presented themselves. And if I was only looking at the traditional route, oh, I'll graduate from residency, I'll take I don't know, a junior faculty position, I'll teach, I'll do this, I'll write some research, I'll like, I don't know that I would have been open to the multiple opportunities that I had, that again were serendipitous. Literally had absolutely no background other than 4 weeks at the VA during residency. And I happened upon this role. I said, oh, I think I can kind of do this. I can work in this managed care office. I'll learn a little bit. It's VA, I'll help some veterans. And in less than a year, I was running the whole office. I was part of the Veterans Health Administration leadership.
Talk about leadership skills.
I mean, it's serendipity that I happened upon that position, but it's also, I truly believe, part of the skill set that you need to adapt and adopt, particularly as women, to be open to those new opportunities where it's maybe an experience that you've never had before. We as women tend to go for experiences that we have always had. It's something kind of trained in us culturally. And I actually do the exact opposite. I always go for the opportunities that I've never had before because I know I can learn on the job.
But let me add something, because something that Dr. Matthews isn't saying is she was able to jump into those opportunities, be offered new, better opportunities with greater leadership and greater influence because she exhibited excellence, right? So it was not enough for her to kind of get the credentials, to take the path, to pursue her interest and passion, but she had to be excellent, right? Albeit mediocre may be tolerated, excellence is really what opens doors and allows you to progress. And now that can't be said for everybody. Now there are some in our community, and I'm not going to go down there, who can, with mediocrity, still be advanced, right? But I would not recommend our watchers and listeners today to do anything other than pursue excellence. And that's how you'll continue to advance and be offered even opportunities outside of what you could have thought or imagined.
Wow, absolutely.
And can I piggyback on that? I love this.
Absolutely.
I'm so glad you pointed that out. I'm so glad that you pointed that out because so many students love to rightfully think through how they can jump into experiences right now. Like, how do I get on the path that you've been on? So number one, neither of us really had a carved out path. So our answer is going to be, we don't know. You have to kind of, figure that out and find the mentors and be open to the opportunities as you go. Number one. But number two, hands down, yes, Dr. Greg, you need to excel in your immediate experiences. So for you right now, you need to graduate from medical school. Don't get distracted and take on all these different opportunities, especially a lot of students. And I love doing this, the ones that are considering law as well as medicine, like Mr. Williams here in the comment and everything. Don't get caught up in wanting to go into the policy work and get into all of that bigger focus right now. Focus on medicine. You need to be first and foremost a strong clinician to occupy any of our leadership roles. And so I would definitely co-sign the excellence piece, that every new role you take on, you need to excel. You need to not be so forward looking as well, that you're missing what you should be accomplishing, how you should be performing, how you should be learning in your immediate experience.
Oh man, I love it. Hold on. Takara, I know you probably want to speak, but I got to
go on.
It's so key. What you said is so key. Like, I think, I'm not going to quote you, but you said, don't be so forward looking that you're missing on the opportunity of right now. And I think all too often, we can think about, what's next? What's the next? You get in one position, one role, one seat, one opportunity, such as medical school, or you get your first job. You're like, well, what's next? No, maximize now
Wow.
before you start to go to what's next. Yeah.
And I agree. Especially in this medical career, we're always like, okay, we got accepted to medical school. Now what? Okay, now we have to focus on getting accepted into residency. And then what? What about our fellowship? Okay, so then we got to do the fellowship. And then what? And then oral boards. And then what if I'm an assistant professor, an associate? So it is. I do see that what's next. Even in my personal life, I'm like, okay, I'm here. What's next? And so sometimes I really have to just soak in the moment and be like, wow, I need to be present in what I'm doing now and make sure that I'm actually excelling in the current rotation I'm in, not, the next one coming up. Sometimes I'll start studying for my next rotation while I'm actually in one. And I'm like, wait, I need to focus on this one. But let me get ahead in PEDS because I know I have PEDS in 2 weeks. And it's like, are you really excelling in internal medicine right now? And it's like, no, you need to pause and excel here. So that was some great feedback because it happens, unintentionally sometimes. So thank you for that and for giving that advice out here to our audience as well. I do have a next question. I'm going to check the chat just to make sure that no one else. Okay. Our same person who gave us that question from Facebook said he did receive those messages from each of you. And thank you, Dr. Gray and Dr. Matthews. Blessings and blessings. Thank you. So my next question, in your experience, can you talk about any ethical dilemmas that you have personally faced in your non-practice roles, and how did you navigate them?
I can start. And I won't say which of the roles it was, but I became aware of a partner as in an organization that was a partner to organization I was working for that was doing some things that were I thought were unethical. And my immediate response was, and I still to this day think was the right decision and would say others to do the same, was to notify my team effective immediately. We are not working with this organization. I think when you identify unethical behavior, it is your responsibility to take action, to not be a silent observer, to not tolerate it, whether or not you're running the organization or a kind of a member of the organization, is to take action. And that was the action that I chose to take. For that, I think, and I go back to one of my mentors as a gastroenterologist. He hired me into my first role as a gastroenterologist at Ohio State, Dr. Darwin Conwell. He told the story of when he was doing, he did some both basic science and clinical research during his career. And there was one point when he had done some research and there was, you kind of he had some results. All the results were kind of mostly around a mean. But there was one that was a far outlier. And his mentor, to whom he initially presented his findings before publishing, said, "Oh, just throw that outlier out. Don't publish that, cancel that data, throw that out." He had to face that decision. Again, this is his mentor, right? This is who kind of brought him into that project and kind of paved the way for him. And he fortunately had good counsel around him, so good friends and peers who said, there's always going to be something that's an outlier, something that's different. And you have to make a decision on your honor, on your reputation, on your integrity, whether you're going to do what's right. And so he did what was right. He published it with the outlier. And that's, widely published study, cited study that he published. And it was important that he did that. If he had not, they have faced many consequences because of that.
Wow.
Yeah.
That was very brave. In some situations, it's kind of hard if you're a mentee to speak out against your mentor, even if they're doing something that's in the gray or sometimes strictly in the black. It's not even the gray. So that was very courageous. And thank you for giving us hope to stand up and it being a light outcome and not, or scared of blackmail or being sabotaged or not able to advance in our careers if you speak up against people. But I guess that doesn't always happen. So thank you. Dr. Matthews, would you like to address that question as well, or would you like us to move on?
I'm trying in my mind to sterilize it a bit. So I do like Dr. Gray and not necessarily disclose. There was a program that was long-standing that I became in charge of that I quickly recognized was missing a fair amount of governance to a scary point, to a point that I think it could ultimately equate in patient safety issues. I'll describe it like that. And the ethical dilemma was the program was in place, it was running smoothly, patients were having their needs met, although I thought that was doubtable because we weren't measuring it at the time. And so everyone's like, just stay quiet, like don't rock the boat sort of response. But I saw real, I mean, it was more than inefficiencies. It was just unacceptable. There was absolutely no structure to this program. So I did my best to kind of shut it down. Like I had no other way to approach this. It is not relevant how long a program has been running, how established it supposedly is as far as outcomes and the like. If you come into having now the responsibility, the accountability over an effort that you didn't initiate, but that you are now responsible for. I truly thought it was an ethical. I didn't consider it a dilemma. I said, no, we're shutting this down. It was an ethical issue for me to allow it to continue, because in shutting it down, I was actually therefore shutting off access to care in a way. But it in no way had safety guards around it. It was in no way being measured. We weren't doing anything proactively to even assure that wasn't happening. It was pretty, I thought it was pretty dangerous. So I think the points of all of these situations are that you do have to be true to yourself. You have to be true to the people that you're serving. And you have to acknowledge your own values. And I think, honesty is by far one of those. Do no harm, obviously, is one that we all have accepted. But for me, kind of appropriate, I don't know, I guess this is the lawyer in me, like governance, like programmatic infrastructure is so important to me that I don't care that there were some benefits being gained in a small way from this established program, that we needed to replace it. So I didn't shut it down without moving to the next option, but I did take immediate action. And that's actually one of my values, not sitting back and accepting a problem, but actually pushing for the solution.
Wow. Thank you. That sounds like
I hope that was generic.
yeah. Well, it was generic and direct, when
I don't want to get anybody in trouble.
No, that is not the goal. But when you see something that can affect patient safety, that definitely to speak up and to speak up right away and to prevent it from happening in the future. So that's our ultimate goals as physicians, right? Is to protect our patients. So thank you, Dr. Matthews. We do have about 10 more minutes left because we're going into 9 o'clock Eastern time. And we do have one question from the audience. So I will ask that. And if we have time, I'll ask one more. So potentially 2 more questions and then a nice closing. Is that okay?
That's fine.
Awesome. So we do have a question from Jade. She says, do you have any recommendations for what to do during residency and immediately post-residency to seek out alternatives to clinical practice? Is seeking out mentors the main goal?
I would say, during residency or post-residency where you are just be engaged in that opportunity and at that institution. So, for example, where you go to residency or where you may go after residency, we'll have invited speakers that come. And not all speakers that come to institutions, depending on the institution, are practicing clinicians. Many have gone other places or done other things at some point in their career. And so just being curious, asking questions, yes, seeking mentors. And that those things can happen at conferences too. So sure, you may have your traditional academic or clinical focused conferences, but there are other opportunities for conferences as well. I mean, look at SNMA. You all have an amazing conference with amazing speakers that come in. Get to know the folks that come in and travel in to speak there, or have exhibits and booths there. Exchange, get their business card, send them an email, give them a call, reach out. So yes, definitely be proactive and take advantage of the environments you find yourself in, both in residency and post residency.
I think that's exactly.
I just wanted to 2 seconds. I'm so sorry, Dr. Williams. I don't mean to interrupt you. Just to shout out AMEC that's coming up because you brought up our conferences. And so just for the audience, SNMA is having our national conference, AMEC, in New Orleans this March. And I don't believe we have sold out yet. So if you did not get your tickets, please.
No, it's sold out.
It's sold out?
It's sold out.
No
Yeah.
way.
It's now the buzz in multiple chats.
Oh, wow. Okay. Well, never mind. We will proceed.
They're looking for more options to assure students can find registration. More to come. Yeah. I think you're exactly right. I think it's more than just mentoring. The networking and the mingling, that sounds so blasé, but I think seeking out opportunities where you can learn more about roles is always going to be important. And yes, a mentor can help with that, but it doesn't have to be that established mentor relationship. I think sometimes students get nervous by the concept of finding a mentor, because that can be a more kind of high touch relationship. It could really be, a faculty member, someone like Dr. Gray and I that you've met through a program at SNMA, at any conference, and you just have a conversation. It doesn't have to turn into something longitudinal, but you have a conversation about our experiences, you learn more, and then you go do your research. You go and learn a little bit more on your own. So I definitely think that's an important point, even now as medical students, but yes, definitely as residents, and then as you're looking for your experiences afterwards. I usually recommend, if you are interested in stepping up beyond clinical roles, whether it's your first position or the second or the third, I have no problem with changing positions. As you can hear, I've only been in practice for like 10 years and I've already had 5 positions. But I always recommend, in your first, second position, aim for a smaller leadership opportunity, whether it's chairing a committee, even serving on a committee. Every hospital, every clinic you join needs some clinician to step up and take a role. It doesn't always fall on the chief medical officers, the medical director's shoulders, nor should it. And there are experiences where you can, again, learn on the job, learn through those committee meetings, get an understanding of some of the business side of medicine. I usually recommend that take that smaller role. You're definitely not going to be experienced enough to step into a leadership role right out of residency. So in your interviews, finding out what opportunities there might be, if they are open to having some of their clinicians, maybe having a little bit of their time to serve on committees, to take on quality, safety, credentialing, medical staff. Every hospital, every health system has all of these different opportunities. Take on some, managed care roles. That's how I got into the managed care side at UIC. I said, sure, let me try this. I've never done it before. And I learned as I went. And then again, I got to the VA and was actually running a full program. So there are opportunities even in your clinical roles to take on some non-clinical responsibilities.
Oh, thank you. I appreciate the feedback from both of you. We do have 3 minutes left. We're going to wrap up shortly. I do have one last question for the both of you. And this question is, for students who are uncertain about their future career paths. What advice would you give them for exploring different options and making informed decisions?
You want to take that first, Dr. Matthews?
I'm sorry, was that too much of a curveball?
No, not at all. I think I'm trying to think. Because that could be specific. There could be different branching points, right, for that uncertainty. It could be, are you questioning maybe specialty choice? I mean, that in and of itself is the whole reason for sowing seed. So I will refer to the rest of your series to think about that. But then let's say you've chosen your field, and so then the question is, do you want to stay in academia? Do you maybe want to go into private practice? Do you want to go into federal service? Do you want to join maybe military medicine? Do you maybe want to go into managed care and take on some experiences in utilization management? There are many different paths that are branching points at any really given moment within your career. I would say number one at the top of my list is just have conversations with people who are in those different options, that are on those different career paths. That's the only way that you can gather the right data. Think of it as kind of data collection to then make a decision for yourself. You're never going to have a mentor, no should you have a mentor, tell you, go do exactly this. You need to figure out your own path, but the only way to do that from an educated basis is to gather that data yourself. Because no one that I know of that I was exposed to had taken a path that I have now created for myself. I'm sure the same for Dr. Gray, and that's going to be the case for so many of the students that are watching. So the informed decisions come from the data collection. You guys are scientists, you know what it is to collect data. So talk to as many people as possible, attend conversations like this, so that you truly have a data set to make a decision from.
Gotcha.
I couldn't have said it better. Network. Yeah.
Yes. I've been learning how important networking is, like, throughout the medical career. And at first I thought it was all academics, like, just got to do well. And then I started going to more conferences, talking to people, and doors just started opening up. I'm like, geez, I should have started talking to people from year one. So yes, networking is number one. Well, up there. But thank you both. We really appreciate it. Both of your experiences and answering our questions and giving a different perspective to medicine. Just honored to have both of you here tonight. Thank you so much, Dr. Gray and Dr. Matthews. Do you want to end on any last notes for tonight?
Ladies first, Dr. Matthews.
I guess I want to say, if this was an interesting topic for you to see, right, on whatever social media you saw this advertisement on, I say bravo, because I think the pressure often from your faculty, I know I receive this, is to do what they're doing, right? Like to focus in clinical medicine, to focus on academia. But if you're already recognizing, hey, I want to take this path, but I want to do it different. I see there's another side to medicine I want to explore. Bravo. Like, persevere through this, because we do need you, like Dr. Gray said earlier, we do need more clinicians taking on these additional roles. This is what will make healthcare better. This is what will make the system better, make it better for our patients. So yeah, bravo, keep it going, keep looking for these opportunities, and do as best you can not to give in to the pressure. I actually had the nerve of one of my faculty members at Hopkins, but what else can you expect? He was like, why would you go into family medicine? I was like, because the rest of the globe practices family. Like, I just pushed back. Like, there was this incredible pressure they didn't understand when I was there. They didn't understand primary care. They didn't understand why you wouldn't be a clinician and do research and I was like, I don't want to do any of that. So, just bravo and persevere.
And I would just say, one, just recognize that no decision you make today is permanent. You may decide, hey, I want to go do internal medicine residency. Then you pivot and like, no, I want to do surgery, or I want to do this, take this career path, and want to pivot and do something different. That's totally fine. Give yourself room and space and grace to do those things. And then the second thing and last thing I'll say is, look, even though we have pivoted out of clinical medicine and doing things that are completely aligned with our purpose is not just this job or role or sit that we or seat that we sit in. There is so much that in order for us to be healthy, we have to explore. We have to explore our relationships with other people and in my case, my faith and things like that. So keep that in mind, particularly as you're going through medical school and residency and fellowship. Those are hard years. Those are time intensive years. Make time for yourself, make time for your relationships. One of the best decisions I ever made, hands down, actually the best decision I ever made, second in getting saved, was marrying my wife. So I'm a husband of 13 years. I have 4 kids, and they helped me to be more effective in my job today. There's no question that I would be able to do. I would not be able to do what I do today without a supportive family. So keep that in mind as you're progressing through all of these different career pivots and decisions. There's more to life than this career. So.
Mm-hmm. Thank you. Wow. And congratulations.
Thanks.
All right. Thank you guys. We really enjoyed the conversation tonight. And thank you to all the viewers who tuned in and asked questions. We appreciate you guys as well. And that will conclude Sowing Seeds, Other Sides of Medicine, Not Practicing. Have a good night.
Thank you all.
Thanks so much again.